Hello everyone, and welcome to our webinar, Kidneys and Hyperphosphatemia, Be Aware. My name is Hélène Boisvert, your host for this webinar today. I'm the Program Director for the Quebec Division of the Kidney Foundation. I've been involved with the Foundation for several years in the realms of prevention, patient services, and organ donation. I'm involved in several committees within the organization, reporting to the Minister of Health. Before starting, I'd like to give you some details on the ways that you can participate in the activities today. By default, our presentation will be broadcast to your computer using the audio system and your computer speakers. If you'd prefer to join us using a smartphone, please tap on the arrow marked Mute Unmute at the bottom of the Zoom screen. Select Switch to Phone Audio, and then Phone Call, and then follow the directions to establish the connection. All of the participants will enter the webinar with their inputs muted. Thank you to all who submitted questions by email. We may not get to your exact question, and we are not in a position to offer official medical advice for specific circumstances. Thank you for your understanding if we don't answer your exact question. For those joining us on their computers, you can send your questions to our guests by writing in the questions box in the control panel. We ask you not to use the chat box to submit questions. We can get to the questions more efficiently when they're submitted using the questions option. You can send in your questions at any time during the presentation. We will organize them in order to respond to them during the last segment, where we will do a question and answer session. You may receive a response from our moderators. For privacy reasons, please do not use your full name when asking a question, and please do not share any personal information. Today's webinar will be saved for future viewing, and you should receive a follow-up email within 24 to 48 hours with a link to the video. Here's a quick description of today's topic. The kidneys are responsible for the chemical regulation of bodily fluids, especially blood. When the kidney is weak, certain substances can build up in the body that would normally be filtered out by the kidneys. One of these substances is phosphorus. Hyperphosphatemia, which is elevated levels of phosphorus in the blood, can be very harmful. It can cause an instability of blood calcium levels and the regulation of the parathyroid glands. This can cause symptoms such as itching, as well as a progressive weakening of the bones, and more concerningly, the crystallization of this excess phosphorus with calcium, which can form deposits in the arteries. This can cause blocked arteries and contributes to a range of other complications associated with kidney dysfunction. This webinar will explore the problem of hyperphosphatemia and various treatments to control or ideally avoid hyperphosphatemia, and will give you the opportunity to ask your questions to specialists in the field. I'd like to introduce our guests today. Their complete biographies are available on our website. Dr. Paul-René de Cotteret studied medicine and internal medicine with a residence at McGill University, followed by a residence in nephrology at the University of Montreal. He was a funded researcher on the Medical Research Council of Canada, obtaining a master's in kidney biochemistry. Since 1986, he's been working as a nephrologist at l'Hôtel-Dieu de Québec, and also as a professor and head of the nephrology division at Laval University's School of Medicine. In 2016, he was awarded the Carrière Prize by the rector of Laval University, and in May 2017, he was recognized as the best teaching clinician by the Medical Association of Quebec. Our second presenter is Roxane Papineau, who holds a bachelor's in nutrition from Laval University, which she completed in 2005, as well as an advanced specialized diploma in functional nutrition and health from Laval University. She's been a clinical nutritionist specializing in nephrology at the University Institute of Cardiology and Respirology of Quebec for about 15 years. Along with her credentials in clinical nutrition, she also holds a doctorate in pharmacy from Laval. She's the president of the Quebec Nephrology Nutritionists Association and a member of Devenir, which is a multidisciplinary group focused on nephrology, as well as a member of the Health Ministry's Committee of Experts on Kidney Health. She's developed several teaching tools for patients and has authored 2 recipe books for kidney and heart patients. Émilie Bachand-Duval holds a bachelor's in pharmacy as well as a master's in advanced drug therapy from the Faculty of Pharmacy at Laval University. She's been a clinical pharmacist at l'Hôtel Dieu de Québec at the University Hospital of Quebec since 2010. Since she started her practice, she's been focused on kidney patients, whether in a dedicated nephrology teaching unit, at her pre-dialysis clinic, at her ambulatory dialysis clinic, or more recently in the realm of kidney transplants. She is part of the scientific committee for the Devenir Foundation and has been a member of the Association of Pharmacists Specializing in Nephrology since its creation in 2016. She's been honored to share her passion for teaching by giving doctorate and master's level courses at Laval University. And now I'll ask Dr. Paul-René de Cotteret to begin his presentation. Thank you. The presentation is on the calcium-phosphorus axis in normal circumstances and in kidney dysfunction. Dr. de Cotteret appears to be on mute. He says it works better when the microphone is on. That was just to make sure everyone was paying attention. Honestly, I'm honored to be a part of this conversation. The subject of the calcium-phosphorus axis is very important for people dealing with kidney disease, but not very well known. So the goal today is to demystify it and to explain it in simple terms, using examples and illustrations. I've tried to avoid complicated science in order to explain it in the simplest possible ways. By the end of the mini presentation, which will be about 15 minutes long, we'll have gone over 4 different substances involved on 5 different types of tissue in the body. And we'll go over 2 strategies to control this type of disorder involving calcium and phosphorus in kidney dysfunction. I'll start with an overview of kidney dysfunction, present the agents involved. There are 4, and present a sort of calcium-phosphorus scenario, drawing on sort of a theatrical presentation as a metaphor. The tissues are sort of the backdrop where the actors or active substances which are interacting at that level. We'll look at how this works normally, and then what I call the Greek tragedy of kidney dysfunction, which is when the system loses the ability to regulate itself and becomes toxic. This will bring us to looking at 2 main strategies that are used to manage this, which will then bring us to the other presentations. What happens when the kidneys are sick or injured? There is a deficiency in the excretion of waste, so things can build up in the body. There can be too much potassium, too much hydrogen, too much acid in the blood, too much salt or water, which can lead to edema or pressure, or too much phosphorus, which is what we're looking at today, and of course, other types of waste. The kidney is a gland that secretes hormones, and this function can become deregulated. For example, buildup of certain hormones will cause high blood pressure. Erythropoietin, which is involved in the creation of red blood cells, can become deficient, causing anemia. And what we'll be focusing on today is the production of activated vitamin D by the kidneys, known as calcitriol, and it's essentially a deficiency in the excretion of phosphorus, a deficiency of production of calcitriol, along with other factors which lead to the phosphocalcium disorders. Without further delay, I'll introduce the actors of interest, starting with calcium. Calcium is a critically important substance within the blood. It controls the electricity of our cells, the contraction of our hearts, nerve function. It's important all over the body. It's important in blood clotting. It allows proteins to function properly to prevent hemorrhages. And in fact, calcium is so important that there are police watching it. The police are called the parathyroid glands, and they're located in the neck. It monitors the calcium to make sure there's enough. And if the glands think there's not enough, the glands will excrete a substance called PTH, which will try to find calcium elsewhere to correct the situation. The next actor is phosphorus, and let's look at how it works with calcium. So the four actors, we've named two, calcium and phosphorus. We've mentioned parathormone, or PTH, the hormone from the parathyroid gland that tries to salvage calcium if there seems to not be enough. And then also calcitriol, or activated vitamin D, a hormone produced by the kidneys, and now we'll have action. Now we'll look at the tissues that these substances act on. Traditionally, there are four, but we'll also look at a fifth. The four classic ones we've spoken about for a long time are the digestive tract, which is implicated in extracting phosphorus and calcium from food, the bones, which is where most of the body's calcium is stored, the kidneys, which eliminate excess phosphorus and produce active vitamin D, and the parathyroid glands, the calcium police, which rather than checking speeds on the highways, are constantly checking calcium levels in the blood. And if the levels seem wrong, then they try to adjust them. Also, we'll add a fifth. When there is deregulation in the other systems, calcium and phosphorus deposits can form in the blood vessels and heart. And these are important factors when it comes to cardiovascular illnesses and mortality in kidney patients. It's a big reason why we try to control these problems related to phosphorus and calcium. So first, we'll look at how this works normally. The illustrations are simple, but I think they do a good job of explaining the situation. So here we see a healthy person. So they'll eat. There's the digestive tract, the kidneys, and bones. The little red dots represent the parathyroid glands, which monitor calcium levels. When we eat, we absorb calcium and phosphorus, and largely these are stored in our bones. The kidneys produce activated vitamin D, which encourages the absorption of these substances so that there are enough, and then the calcium levels are detected by the parathyroid glands. In a normal situation, they are satisfied with the amount of calcium that they detect, and they secrete a moderate amount of PTH, which will go to the bones. In effect, it allows new calcium and phosphorus to bind to the bones. Somewhat like what Quebec's Transportation Department should be doing, allowing things to flow smoothly and getting rid of bumps in the road. Luckily for us, at least within the body, this normally works well. And the bones you have today are not the same as the bones you had years ago. They slowly change from day to day, delicately stripped down by PTH, and then repaved with new calcium and phosphorus. Finally, the phosphorus from our food, which Roxanne will go over later. In a normal situation, the excess phosphorus is filtered out by the kidneys so that it doesn't accumulate, which is crucial. So now we'll look at the Greek tragedy of renal dysfunction, which happens when the kidney is ill and is incapable of producing calcitriol and incapable of filtering excess phosphorus into the urine. We'll look at the same diagram here, but we'll assume this time that this person has kidney dysfunction. Their kidneys aren't working well. First of all, they will absorb nutrients. The digestive tract works properly, so if food goes in, it's able to extract phosphorus from a lot of foods, which Roxanne will cover later. So the phosphorus enters, but the excess isn't filtered out or isn't filtered enough into the urine. For this reason, the phosphorus is indicated in larger text here. A buildup of phosphorus in the blood from diminished excretion in the urine. So there's a weight that builds up to excrete it, and there's too much phosphorus. At the same time, we have less calcitriol being formed by the compromised kidney. So the absorption of calcium is reduced, and for this reason, the calcium is indicated in smaller text here, because we have what we call hypocalcium, or a lack of calcium in the blood, an excess of phosphorus, and a deficiency of calcium. So as you may have guessed, this lack of calcium will be quickly detected by the police. The parathyroid glands will notice the lack of calcium and will become concerned and start to produce large quantities of PTH, which is absorbed by the bones, creating ridges and grooves in order to release as much calcium and phosphorus as possible to raise the blood calcium level. If you look here at the letters, you'll see that the blood calcium is increased with this excess in PTH, excessive wear on the bones, and we see that the blood phosphorus levels go up as well. And when you have too much calcium and phosphorus, it won't dissolve. It precipitates into small solids like snowflakes, but they don't melt. It's a solid mineral, and it becomes stuck in the blood vessels. Damages the cardiovascular system, and this is what we're concerned with. So the cardiovascular system is one of those tissue types that's impacted by this problem, and that is worrying to us. The following graph shows why. This shows cardiovascular mortality according to age, so you can see that with the general population, mortality increases steadily over time. You don't really need a webinar to explain that the older people get, the more likely they are to die. But in fact, for people undergoing dialysis, this is the mortality curve. And it's not showing that mortality no longer increases with age. It shows that someone undergoing dialysis at age 25 is about as likely to die as their 85-year-old grandfather. And this catastrophic excess mortality for dialysis patients, we think that it's partly because of these problems with phosphorus and calcium, and these crystals of calcium and phosphorus that form deposits in our blood vessels and can cause blockages and dysfunction. So finally, what do we do with all this? Essentially, there are two main things that should be done. Like a video game that we play with our children, there are two goals to achieve, and once we achieve them both, we pass the level. The first goal is to lower phosphorus levels. There's too much phosphorus because the kidney can't filter it out quickly enough. Because the PTH scours the bones, and this releases phosphorus. And also we need to lower PTH by calming the parathyroid glands in order to bring the extractions of minerals from the bones to a normal level. So if we can do all this, we get a medal. In terms of strategies, to control the raised levels of phosphorus in the blood, hyper meaning too much, so hyperphosphatemia is too much phosphorus in the blood. So to control that, we reduce consumption of phosphorus, and with food that does contain phosphorus, to reduce the absorption of phosphorus using chelators, which are like bits of Velcro that bind to the phosphorus and prevent it from being absorbed by the stomach and the intestines. So controlling the intake of phosphorus and lowering the levels of PTH by using activated vitamin D, and in some cases using medications to regulate the parathyroid glands, a drug called Sinsipar. And if this doesn't work, or the parathyroid glands are enlarged, surgery can be done on the parathyroid glands to improve the situation. So that's a brief overview of the phosphorus and calcium issue. I will now pass things over to Roxanne. Hello, everyone. Thank you, Paul, for that excellent overview of the strategies on the table to control hyperphosphatemia. It's a great pleasure today to present on the nutritional aspects of phosphorus. It's a subject that touches me personally. I really enjoy talking about phosphorus because it's something where nutrition can have a really big impact. So with patients, we find strategies to control the amount of phosphorus in their diet. So let's look at what our phosphorus needs are. The daily phosphorus needs for adults is about 700 milligrams per day. Unfortunately, when we look at Canada, the average intake is much higher. We don't have more recent data, but in 2004, the average intake was about double what is needed for both men and women. So we eat a lot of phosphorus. And that doesn't even include phosphorus, which is added in the form of phosphates, which I'll talk about later. So at base level, we do eat a lot of phosphorus. And the reason that we eat so much phosphorus is because we tend to eat a lot of protein in North America. The main source of phosphorus in our diet is protein. For every gram of protein that we eat, there's about 13 to 15 milligrams of phosphorus connected to these proteins. The North American diet tends to be heavy in proteins, and actually protein consumption is increasing. So for this reason, our consumption of phosphorus is also increasing. So we see here that protein consumption has been rising steadily. And if we look at the average of about 100 grams of protein per day, that amount of protein would include approximately 1.4 grams of phosphorus, which is about twice as much as we need. And again, this is tied to our heavy protein consumption. Other than proteins, we know that phosphorus is contained in foods in different forms. We can have naturally occurring phosphorus. We'll call this organic phosphorus. And this is present in foods derived from animal and plant sources. We'll speak more about this later. There's also what we call inorganic phosphorus, which has been added by the food industry in the form of phosphates. What we've known for several years is that on top of the phosphorus contained in these foods, their impact on blood phosphorus levels will vary between the forms because they are absorbed at different rates. Phosphorus is absorbed by the intestines at different rates depending on the source of the phosphorus. So phosphorus from animal sources represents about 50% of the phosphorus consumed by the typical person over the course of the day. It's found in meat, poultry, fish, eggs, and dairy products. Generally, there's a bit more in red meat compared to poultry, and a bit more in oil fish like salmon or trout compared to white fish. It's tied to protein, as I mentioned, and we estimate that about 50% of this phosphorus is absorbed by the intestines. So if I consume 300 milligrams of phosphorus in a piece of chicken, on average about 150 milligrams of this would be absorbed by the intestines. But the rate of absorption is greatly increased if the food contains added phosphates, which is common in cold meats, frozen fish, and processed cheese. So that's where we really see high levels of phosphorus in foods. You see here examples of different kinds of cheese. We see the amount of phosphorus in milligrams in cheese, which can be less than 100 milligrams per serving to over 500 milligrams. So at the top of this list, we find processed cheeses like Cheese Whiz, Velveeta, Kraft slices, which contain a lot of phosphorus due to the added phosphates. Then we see with fresher, less processed cheese that there's generally a bit less phosphorus. There's a tendency for a bit more phosphorus in light products compared to regular products. In terms of plant sources, we're talking about fruits and vegetables, which do not contain much phosphorus at base level, but also things like nuts, seeds, legumes, whole grains, and cacao. Phosphorus in the foods I listed is often in the form of phytic acid, or what we call phytate. It's a form of phosphorus that needs to be digested by an enzyme called phytase in order to be absorbed. Unfortunately, or fortunately for kidney patients, the human body doesn't produce this enzyme itself. So this makes the phosphorus less available to be absorbed by the intestine. So when we eat legumes, even if there is 200 milligrams of phosphorus, only about 10 to 30% is really absorbed by the intestines. So only 20 to 30 milligrams of phosphorus would be absorbed into the blood. So you'll understand that there's a lot less impact from plant sources on the total amount of phosphorus in the blood compared to animal sources, even if they sometimes seem to have high phosphorus content. I've been involved in nephrology for 15 years, and before we understood this information on absorption rates, the old recommendations were often to limit legumes, nuts, and whole grains, but we no longer recommend this because we now understand they don't have much impact on blood phosphorus levels, and additionally, they tend to have other health benefits, especially for the heart, less acidity in the blood, less cholesterol. They're a source of antioxidants. So for these reasons, we tend to encourage people to eat these foods. On the other hand, where we need to focus a lot of energy is on reducing phosphorus in phosphate additives. The food industry increasingly uses additives in food, and phosphates are among the most common. It's a type of phosphorus that's not contained in protein or in phytate like in vegetables, so it's an additive that's easily hydrolyzed and digested at a rate of nearly 100%. So if there's 100 milligrams of this phosphorus in our food, nearly all of it will be absorbed. And we realized that we eat more and more added phosphates In the 1980s and 90s, we ate about 300 to 500 milligrams per day of phosphorus in the form of additives. And in today's North American diet, this can be up to 1,000 milligrams per day. And this is just added phosphorus on top of the 1,000 milligrams of naturally occurring phosphorus that is already consumed. So that can have a big impact on the amount of phosphorus in the blood and the urine. And we also know about other negative impacts these additives can have, not only on the kidneys, but also on the heart, the brain, and can increase the risk of other illnesses. So examples of phosphate additives, you'll see in this ingredients list words like phosphate, phosphite, phosphoric. So when you see PHOS in a food, it generally means that these foods contain phosphate additives, so a source of phosphorus which is easily absorbed by the body. The main sources of phosphate additives, I would say they can be found in almost anything, and it's important to check the ingredients when buying food, but in particular, cured meats, processed cheeses, frozen foods, often shrimp, coffee cream and whipped cream. Often with dairy products, there are additives, soft drinks, especially dark ones, flavored waters. Often vitamin waters have phosphates in them. Cake mixes or baked products, certain types of cereal. So we can really find this type of phosphorus in a lot of different types of food. In terms of nutritional labeling, phosphorus doesn't need to be included in nutritional charts on packaging, like in the charts where you'd see the specific amounts of certain nutrients. It's not usually included there. On the other hand, any phosphate additives need to be included on the list of ingredients. So that's where you'd normally see it. Sometimes the phosphorus is included in the nutritional chart, usually as a percentage. So this means that if I see a phosphorus at 10%, this is based on 1,000 milligrams per day. So this means that the food item contains about 100 milligrams of phosphorus. On the other hand, it doesn't indicate how much would be absorbed. 100 milligrams of phosphorus in one food won't necessarily be absorbed the same as 100 milligrams in another food. So the list of ingredients tends to be the most important to check. For example, a whole grain bread. We'll look at the table. It doesn't contain much sodium, there's a lot of fiber, and then we see phosphorus at 10%. So this can seem like a lot. On the other hand, when we look at the ingredients, we see whole grain flour, and we don't see any added phosphorus in this product. In other words, most of the phosphorus comes from the whole grain, and most of it wouldn't be absorbed, so really this would be closer to 1% of daily needs of phosphorus. Another example, when we buy plant-derived beverages, for example, beverages made from almonds, rice, or soy, sometimes we'll see the amount of phosphorus indicated, and sometimes it's not shown. So how can we know which one contains more or less phosphorus? We look at the ingredients. You'll see on the left, in the ingredients, we find tricalcic phosphate. So the company decided to add calcium in the form of phosphates. So we can see that the 15% indicated here is a type of phosphorus that is easily absorbed. On the other side, it doesn't actually say how much phosphate is there. But when we look at the list of ingredients, we see calcium carbonate. So that company decided to add calcium in carbonate form, and there's no phosphates added. So I would tend to choose the second drink. Here are some other common examples. Dark soft drinks which contain phosphoric acid, Cured meats, which contain sodium phosphate. Frozen shrimp, about 9 out of 10 frozen shrimp brands contain added phosphates. Drink mixes can contain phosphates, and processed cheeses. And often foods contain more than one additive. So this vache qui rit cheese contains 3 different types of added phosphorus. And here's my favorite. I always challenge my patients to find a better one. It's a cake mix that contains 5 different types of added phosphorus. So you can see that some products can contain a lot. We'll also find a lot of phosphates in certain health foods. So some cereals, low sodium broths, some organic products. So the nutritional value of products isn't necessarily all we should look at when we're concerned about phosphorus specifically. Always check the list of ingredients. Baking powder is a hidden source of phosphates. Really, it's not hidden because it's right there on the label. But when cooking with baking powder, that's often increasing the phosphorus content of the food by a considerable amount. On the other hand, there are commercially available baking powders that don't contain phosphorus. So that's interesting to note, and it's easy to make baking powder yourself with no phosphorus in it. Here's the recipe. It's based on cream of tartar, cornstarch, and sodium bicarbonate, which are all available at the grocery store. And we just mix it all, keep it at room temperature, and use it in the same quantities as pre-mixed baking powder. In terms of restaurants, generally at restaurants, you won't have a list of ingredients readily available. Sometimes you can find it online, but generally it may not be easy to find. And often restaurants use a lot of additives, especially in fast food. So probably people's phosphorus levels are a bit better right now, with many restaurants being closed. Right now, people are eating out less often. An example here, a lot of patients go to Subway because it's thought of as healthy. But looking on their website, we can see that there are a lot of additives in their products. That's just the protein there, but it's also in the bread, in the cheese, and I've highlighted the phosphorus additives. If you look more in detail, there's also potassium additives, and it's not just Subway. With most chain restaurants, you'll find these types of additives in their ingredients. It's also important to pay attention to nutritional supplements. These contain vitamins and minerals, and when someone has kidney dysfunction, there are minerals that can build up in the blood, so we don't necessarily want to add even more in the form of supplements. A good example is Centrum multivitamins, which contain a bit of everything, including a large amount of phosphorus. It also contains a lot of vitamin A, which we don't necessarily want to supplement in someone with kidney dysfunction. For this reason, there are multivitamins that are specially designed for people with kidney problems without any phosphorus or vitamin A. If you have any questions about supplements, you should consult with a nutritionist, pharmacist, or doctor, and they should be able to give you advice. For those who take meal supplements for energy, additional calories, or because they have a low appetite or they're in hospital, you should know that the phosphorus content of these products can vary as well. It's generally in the form of additives in these products, and there are specialized products for people with kidney concerns. Suplina for patients in pre-dialysis, which is lower in phosphorus. Nepro for dialysis patients, which also has less phosphorus than more generalized supplements. We also have Novosource Renal, which contains a bit less phosphorus than normal. So again, consult with a new nutritionist who could tell you which supplements would best suit your needs. So as a summary of edible phosphorus in our hyperphosphatemia reduction strategies, we need to reduce excess protein intake, but especially animal proteins. Respect your own needs. Your nutritionist can help explain those to you. Try to integrate plant proteins more often. Avoid products that contain added phosphorus, so make sure you're reading the labels at the grocery store. This also lets you monitor sodium in foods. Limit how much you eat at restaurants and consult with health professionals to help you choose supplements that are right for you. In certain cases, when the phosphorus levels are high, even with an optimized diet, you could also take chelators, which reduce how much phosphorus is absorbed. Emily will speak on those in more detail. Essentially, they're medications that are taken with foods that are high in phosphorus, and there are certain ways of taking them to ensure that they're effective. I'd like to tell you that eating with kidney health in mind is much less complicated than often thought. If you look at Canada's food guide from last year, you'll see that it recommends limiting highly processed foods, limiting foods with additives, eating more whole grains and plant proteins. So it's already good advice for someone who is dealing with kidney dysfunction. It's a diet that's naturally quite low in added phosphorus. I'll finish by saying that for anyone who'd like to know more on kidney-related nutrition, I'm very pleased to announce that my book, 21 Days of Menus for Kidney Health, recipes that are low in sodium and low in phosphorus, will be available in bookstores and online on February 10th. I'm very pleased with this. I'll now pass things over to my colleague Emily, who will speak about pharmacological treatments to lower blood phosphorus levels. Thank you very much, Roxanne and Paul. So I'll be finishing this presentation, which has been very educational so far. For my part, I'm a pharmacist, and I'll be talking about medications that are used to manage hyperphosphatemia. When do we take medications? So Roxanne went over all the little details and traps to avoid when it comes to phosphorus in food. On the other hand, sometimes, in fact, the majority of cases, diet isn't enough to control blood phosphorus levels on its own. So in these cases, we turn to medication, in this case, phosphorus chelators. There are a couple different spelling conventions, but they're both correct. What a phosphorus chelator does is fairly simple. Its mechanism of action, as we'll see, is a sort of magnet that attracts phosphorus ions in the digestive tract. So these little magnets are in the digestive tract, and they attract the phosphorus that's been consumed. It creates an insoluble compound, which prevents the phosphorus from being absorbed. So I've drawn this illustration here. The green circles represent phosphorus, and the purple squares represent the chelator, and the beige here is the intestine. So if we eat phosphorus and take the chelator after the meal, there are some phosphorus ions that are absorbed by the digestive tract. But once the chelator attaches to the phosphorus, it forms a compound that is too large to be absorbed easily. So it doesn't enter the blood and is eliminated as waste. So all of these compounds are not absorbed into the blood and instead just pass through the digestive system. The chelators don't take phosphorus out of the blood, so the only way to really remove excess phosphorus from the blood, other than with natural bodily functions, is through dialysis. So that's why patients with advanced kidney dysfunction who are pre-dialysis sometimes have trouble controlling phosphorus levels, and then they go for dialysis, and the dialysis helps a bit to get rid of the phosphorus. But with normal kidney function, this process is happening 24 hours a day, whereas with dialysis, it only happens for a few hours each week. So that's why sometimes it takes medication as well. Continuing on the topic of phosphorus chelators, as Roxanne mentioned earlier, in order to be effective as magnets for attracting phosphorus, they need to be taken with meals, sometimes with snacks if necessary, depending on the types of snacks that you eat. In terms of the medications, they'd be taken 2 to 3 times a day or more. Some of my patients who are diabetic and eat high-protein snacks at the end of the day, in these cases, it can be good to take a chelator with this high-protein snack, which can help further to reduce phosphorus levels. Several options exist in terms of medications. Which one is chosen will depend on the patient's characteristics, how high their phosphorus levels are. There are several possible combinations. You'll see them in the next diagram. And certain combinations are more powerful than others. The goal is to bind to as much consumed phosphorus as possible. The most popular phosphorus chelator is calcium. Most of the time, it will be in the form of calcium carbonate, often as big green pills that are about the size of your fingertip. It's the first choice of medications. It's effective, it's easily available, it's not expensive, and normally it's well tolerated. So for all these reasons, it's our first choice of medication. There are not many side effects. Occasionally, constipation or abdominal discomfort, but most people tolerate it well. It's a medication that's easy to access. You'll see some of the other chelators have additional steps, depending on the province. In Quebec, we have easy access to some other chelators, but in some other parts of Canada, calcium would be the main go-to. Calcium requires some attention. It can react with certain other medications, for example, some thyroid medications, such as Synthroid. They can also react with some antibiotics. So if you're prescribed antibiotics, just make sure that they can be taken concurrently with the calcium. Your pharmacist, whether with the kidney or dialysis clinic or a general pharmacist, could recommend on that topic. And in terms of availability, calcium is of interest because it's available in a lot of different forms. Often they're in regular pill form, but sometimes people find these hard to swallow, so there are chewable forms. They come in liquid forms as well. Sometimes liquids are a bit less practical because of the quantities involved, but the pill and chewable forms tend to work well for our patients. Even for those who have difficulty swallowing pills, the chewable ones usually work. Another popular alternative is magnesium. I've noted it here. It's not used as much these days, but it is sometimes prescribed. It's again very accessible, quite effective, although a bit less than calcium. Easily tolerated. Sometimes diarrhea is a side effect. The problem with magnesium is it's less effective than other chelators. So for that reason, it's mostly been forgotten about, but it's good to note that it is another option that can help to control phosphorus levels. So once we've started on calcium and optimized the diet, often there are questions about when the calcium should be taken with meals. So as I've mentioned, there needs to be food in the digestive tract, and then we can use combinations of different chelators. Chelators that can be added to calcium include sevelamer, lanthanum, and sucroferric oxyhydroxide. It's a complicated name that we'll see again later. These are three good options, and is a choice that you could discuss with your pharmacist or your doctor or nutritionist to decide which is best for you. Each chelator has certain advantages and disadvantages, and these can be taken into account when choosing which ones to use. The first option, which is commonly used, is sevelamer, which is also called Renvela or Renagel. Those are similar medications with the same main active ingredient, sevelamer. It's the white pill you see at the top of the page. So it's about the size of the tip of my little finger, similar to a calcium pill. Renvela is used when calcium isn't enough, even when it's been used as a chelator. If the phosphorus levels are still quite elevated, in that case we'd add Renvela or Renagel, or sometimes we would use this first if people have conflicting medications or another reason they shouldn't take calcium, like high blood calcium levels. So in that case, we'd go directly with Renvela, which is a good option as well. It's an effective medication, a bit more expensive. In Quebec, it's considered a medication of exception, so kidney patients can generally claim Renvela with RAMQ or another insurance provider. In some provinces, there would be additional steps, but generally it's accessible with a bit of coordination with your doctor or pharmacist. So that's something that's available as well. Renvela and Renagel, one of the negative effects sometimes reported by patients is that it sometimes takes several pills per meal for it to have much effect. So rather than just taking one very strong pill, often people end up taking 2, 3, or 4 Renvela pills with their meals. So some people can find that inconvenient. Some people would rather just take one pill rather than having to take a whole bunch. Sometimes it doesn't feel practical. Other side effects include digestive discomfort or nausea. These are sometimes reported, especially with high doses. But generally, it's effective, well tolerated, and safe. Renvela is available in pills. It's important not to chew these. If you chew them, it will foam up and not work as effectively. So if you're taking Renvela, you eat, then you take the Renvela, and the Renvela will take its effects on the digestive tract. If you have trouble swallowing medications like Renvela and it's been decided that is the best medication for you, Renvela has been available in Canada in powder form for about 2 years, so that could be an option as well. It can be dissolved in water or added to food. I'll show a diagram about that. A second option that's available is lanthanum or phosphorenol. There's a typo, it should say phosphorenol. It's a big pill, about the size of a quarter. It's chewable, so this is a good alternative to Renvela if calcium isn't enough on its own. So this would be added as well. You take your calcium, you take your phosphorenol, at the time of day or with meals, as discussed with your healthcare provider. It's effective. The advantage of Phosphorus over Salvaging is that it's more powerful. So with Phosphorus, it's like having a more powerful magnet than Salvaging, so usually not as many pills are needed, which can be of interest to patients. It's a tablet that's meant to be chewed, so if it isn't chewed or crushed, it doesn't work as effectively, and it tastes like chalk, so not everyone will like that, but the taste goes away quickly when you eat or drink something, but some people would find it restrictive if they don't like the taste. It can be a bit expensive, about the same as Salvaging. Again, it's a medication of exception. In terms of side effects, we'd be looking again at digestive problems, nausea, and diarrhea. In terms of accessibility, it's a chewable tablet, but it can also be crushed using a pharmacist's tools. So it doesn't need to be bitten on directly. You can crush it beforehand, which can be a good alternative because the tablets are quite thick, and some people, if they have a jaw injury, for example, might have trouble chewing it with their meals. And finally, a newer one, we have sucroferric oxyhydroxide, or Velphoro. Is the medication shown here? It's about the size of a nickel. Again, it's a chewable tablet. It's thinner than Phosphorus, so it's easier to chew. Less likely to make your jaw sore if you're taking it 3 times a day or more, depending on what you've decided with your healthcare provider. Velphoro is a choice on the same level as Salvaging or lanthanum. It's also normally used in conjunction with calcium. As I mentioned, it needs to be chewed or crushed. In addition to being easier to chew, they're fruit flavored, like Tums. So it tastes better, it goes down easier, and patients often appreciate that. We've been using it here at L'Hôtel-Dieu for about a year, and it's been going well. In terms of cost, it's in a similar range to Salvaging or lanthanum. In terms of side effects, it's a bit different. This one can cause digestive intolerance in some cases, but it's important to note that this is an iron-based medication, which is implied in the term sucroferric. So if you've ever taken iron by mouth, you may notice that this causes your stools to be black or very dark. With Velphoro, the same thing happens. So if you take Velphoro and your stools become very dark, don't be alarmed. It's important to know that's normal. It simply has to do with the high iron content. The other thing to know before starting treatment on Velphoro is that it can cause diarrhea or soft stools, but usually these problems are brief and usually only appear for the first 2 to 4 weeks after treatment begins or is changed. So I tell patients who are starting on Velphoro that it's important to tough out those first 4 weeks, and then most patients go back to having normal stools. But it's true that in the first few weeks, some people can find that inconvenient. It's a powerful medication. For comparison, 1 Velphoro tablet can be equivalent to 3 Salvaging. So if the aim is to reduce the number of pills being taken, and the chewable form is convenient for you, that could be a good option as a medication to control phosphorus. Like I said, it's a tablet that needs to be chewed. It shouldn't be swallowed whole. There's a different version that can be swallowed whole, but the chewable ones need to be chewed. The last 3 medications I've covered here are 3 that can be offered when calcium isn't enough to control phosphorus levels on its own. And just to go back to something that Roxanne was saying, when you're prescribed calcium as a phosphorus chelator, for example, twice a day, it's best to take it with the 2 meals that contain the most phosphorus. So that's important to keep in mind. So some advice I can give as a pharmacist. Sometimes people say, I have to swallow a calcium pill and then 4 Ranvilla pills at once. I find this difficult and it gives me indigestion and makes me nauseous. Some people can take their chelator over the course of their meal. It's important to take it with meals, but they could take a bite of food, take one of the pills, have a few more bites, take another pill, and so on. And that sort of spreads out the pills and makes it more comfortable on the abdomen. Because it's true, sometimes 4 pills of that size can be difficult to take all at once. The other trick to know, if you ever miss a meal, maybe you had surgery or you just didn't eat that morning, or you skip a meal for whatever reason, or you have a stomach illness, it's a medication that binds to phosphorus in food. So if you haven't eaten, you don't need to take the chelator. It doesn't need to work in your digestive tract. If there's nothing else there, it won't really have any effect. So if you miss a meal, you can skip a dose of the chelator. If you're not sure which of your medications is a chelator, sometimes it's hard to keep track of what's what, but check with your dialysis nurse or nephrologist or a pharmacist who can let you know which one is the chelator. Generally, they're large pills like I showed earlier, pretty easy to recognize, so it should be easy to remember most of the time. Like I said, if we have chelators with each meal, and despite everything, the phosphorus levels are still high. If we eat some cheese, for example, as a snack, or other foods high in phosphorus, like Roxanne was talking about earlier, it can be helpful to take a chelator at this time as well. Maybe consult with a healthcare provider. You could say, I eat a big piece of cheese when I go to bed. Most of the time, we don't think about these things, but in these cases, it could be helpful to take chelators with these types of snacks as well in order to better control blood phosphorus levels. A few other pieces of advice, like I mentioned earlier, there are 2 pills, Phosphorus and Velphoro, which are chewable, but some patients have trouble chewing them. So something that's available at pharmacies is pill crushers. There's several different types. The one shown here is a common one. It's not complicated. You put your medication inside and twist it, and it crushes the pill. So then you have the powder. You can put this in various types of food, in your meals, or eat it as a powder if that's easy for you. But this is something that can make it easier, especially for people with jaw or dental problems. So it's an option, not very expensive, about $15 to $20 for one of these pill crushers. So like I mentioned, lanthanum or phosphonol and sucroferric oxyhydroxide or Velphoro can be crushed into a powder and put into food. And sevelamer is available in powdered form, which can be used in food. To give an idea of what it looks like, it comes in a packet that you dissolve in about 2 tablespoons of water, mix it, add another spoonful of water, mix, and then drink that. That's if you want it in liquid form, but also you can just put it on food, like the other 2 medications that can be crushed. So whether it's powdered Ranvilla or Phosphonol or Velphoro that have been crushed, you mix it in and eat it. It's important to take the full dosage if you mix it into your drink, but then only drink part of it. It doesn't really help since that's not a full dose. So it works best if it can be mixed into a small quantity of food to make sure that you eat all of it, because if the medication isn't taken in the proper amount, it won't be as effective. So we've talked about phosphorus in food and phosphorus with medications. As Dr. Paul mentioned earlier, sometimes PTH is involved. The parathyroid gland detects that there's too much phosphorus and that there's not enough calcium. What's going on? Sometimes, even when we're doing our best to control phosphorus levels, we need to help the calcium and phosphorus police, that is to say, the PTH, which we can help with medications. So the medications that are used most often are Rocaltrol and 1-alpha. Rocaltrol is calcitriol, which we've talked about earlier, which is produced by the kidneys. And 1-alpha is alpha-calcidiol, which is derived from calcitriol. So these are both super vitamin D. Their function, whether they're produced in the kidneys or taken by mouth in synthetic form, is to say to the PTH, calm down, we don't need so much of you. This is something that's prescribed, often is taken 3 times per week, or sometimes once a day, depending on the level of calcium and PTH in the blood. So it's these little capsules here. You may have seen them before. And they reduce the amount of PTH being created. When there is calcitriol present, less PTH is produced. It's a medication that can be available in a few different ways. Certain patients can receive it during the dialysis process. Other patients who don't undergo dialysis, and really the majority of people, would take it by mouth. It's well tolerated. There aren't many side effects. We would use blood tests to monitor how hard the parathyroid glands are working and the calcium levels in the blood. So that's usually the first thing we would do to help regulate PTH levels. If the PTH doesn't listen to our super vitamin D medications, we would do something more powerful. In this case, calcimimetic, which is sold under the brand names Sensipar and Cinacalcet. So the reason I put a chameleon here is that Sensipar imitates calcium. At the level of PTH, the parathyroid gland thinks that it is calcium and lowers its levels. So that limits the creation of new PTH, or parathormone, by imitating calcium. Most of the time, for these patients, these medications would be for patients under dialysis, although there are some exceptions. For some patients, it can be prescribed before dialysis or following a kidney transplant, but that's more the exception than the rule. It can be taken 1 or 2 times a day each day. The reason we separate it into 2 doses is for tolerance. It can make digestion difficult, and some patients experience nausea when they start treatment or raise doses. So ideally, it should be taken with food, or if this doesn't help, then separate it into 2 doses, 1 in the morning and 1 in the evening. In that case, tolerance is increased for people who are prescribed Sensipar. In terms of side effects, they're generally digestive, nausea, vomiting, stomach pain, or diarrhea. So we can mitigate this by splitting it into 2 doses and taking it with food. And in the follow-up blood tests, we'd be looking at reduction in PTH secretion. So we'd be looking for that, but also looking at the calcium levels in the blood, which sometimes go down, but this is something that is monitored frequently. Sensipar can interact with certain other medications. So if you're prescribed that, your doctor or pharmacist will check to see if there are interactions with any other medications you're taking. And if you start taking other medications later, it's important that the person prescribing it is aware that you are taking Sensipar. In terms of accessibility, it's a medication of exception. Normally, you'd need to fill out a form. It can be a bit of a process, and sometimes it takes a few weeks to be approved by RAMQ. But other than a bit of extra paperwork, it's quite accessible. So with those actors, for a story that ends well, I'll bring you back to Dr. Paul's presentation in terms of the dramatic presentation. It's about better bone and cardiovascular health. All the actors need to play the role and not forget the script, whether that's diet, chelators, vitamin D analogs if required, and Sensipar. These are the actors that have important roles to play in terms of healthy bones, a healthy cardiovascular system. So I hope today's presentation has helped you. I'll now pass things back to Hélène. Thank you. I think each of these presentations was very interesting. It seems that everything was very complete. We had one question and Roxanne answered it, but this morning I had a question myself for Roxanne. And that's, why is it recommended to eat fiber each morning? And why do most cereals contain phosphorus? Really, it comes back to what I was saying in my presentation in terms of plant-based phosphorus. We typically find a lot of phosphorus in whole grains, but because it's phosphorus in phytate form, it's a form of phosphorus that isn't absorbed very much, so don't be afraid of phosphorus in your whole grain cereal unless you see mention of phosphates in the ingredients list. So if we take a whole grain cereal, like the bread we used as an example earlier, you saw that there was 10% of the recommended daily phosphorus, but there weren't any phosphorus additives. So it's not really 10% because it's not all absorbed. The actual amount that would be absorbed into the blood is less than what's indicated, only about 10 to 30% of what's indicated. On the other hand, some cereals like Cheerios, which is generally thought of as a healthy cereal, this has higher levels of phosphates as additives. So if you see a high amount of phosphate, this can lead to a higher level of phosphorus in the blood. And with cereal, we should also think of milk as well. Milk is a major source of phosphorus. And for that reason, we often recommend a plant-based alternative with no added phosphates to really have a meal that's lower in phosphorus. I'll also reply to the question I received in the chat, since it may interest other people. I was asked if Perservision Areds 2, which is a multivitamin especially for the eyes, to prevent macular degeneration, is that an effective choice for someone with kidney conditions? There exist a number of different multivitamins for the eyes, what we call ocular vitamins, which have lutein and other nutrients that are important for the eyes. Some have vitamin A, others don't. With kidney dysfunction, we recommend avoiding the ones with vitamin A. But most of these multivitamins have vitamin E, vitamin C. Often what we'll do with patients is reduce the dose. Instead of taking 2 tablets per day, just take 1. Or other vitamins such as Ocuvite, which contain a lot of things the eyes need, but less vitamin E and less vitamin C than most others. So depending on your needs, there's the possibility of choosing a multivitamin for your eyes that works for you. It's important to go over this with a nutritionist or a pharmacist to make the right choice. Thank you, Roxanne. Another question for Roxanne and Emily, which is a low level of bicarbonate in the blood. And this is not for all situations because it can accelerate other problems. But does low bicarbonate in the blood have a negative impact on the regulation of phosphorus? That's a great question. We've known for some time that low blood levels of bicarbonate, so metabolic acidosis, or low blood pH, can have an impact on the regulation of potassium. So when the pH of blood is too low, rather than going back into the cell, the potassium will stay in the blood, so this leads to increased potassium in the blood. With phosphorus, we don't know this yet for sure. We do know that in acidosis, there is a reabsorption of the bones. So acidosis has a negative impact on muscles as well as bones. A bit like PTH, which can weaken the bones, acidosis also has this effect of weakening the bones. So it's important to control blood acidity, and this is controlled by diet mostly and eating a lot of fruits and vegetables with important attention paid to the acidity. The concept of salvaging minerals from bones is probably not something nutritionists talk about much. Well, we use it a lot in order to illustrate concepts, the idea of crystals in the bones. It's important to be able to visualize what we're talking about so we can understand why we recommend these changes or these treatments. Thank you very much. Once again, we'd like to thank our presenters today on this very important and interesting topic. Thank you also to everyone who has been following our webinar, Kidneys and Hyperphosphatemia, Be Aware. At the end of the webinar, a new page will open asking you to complete a short survey. You'll also receive a follow-up email with a link to the survey if you'd rather complete it later. We'd appreciate it if you fill out the survey and leave comments. Your responses are important so we can continue to improve our webinars. So we'd ask that you take a moment to complete the survey. You'll also receive an email in 24 to 48 hours with a link to view a recording of today's webinar. On behalf of the Kidney Foundation and our collaborators, thank you for having been part of today's activities. Take care and have a good day.